All right, so finishing up in chapter 8, we're talking about joints or articulations, and we had gone through some of the simpler types of joints, right? Remember there was two ways to classify them: structural, functional. Structurally, we talk about fibrous joints, we talk about cartilaginous joints, then we got the synovial joints. And synovial joints, we spent a lot of time there. We were talking about the structure of a synovial joint. We talked about the different types of movements that you can get at synovial joints and the terms for those. And now we're going to look at a couple of things. 6 different types of synovial joints, again determined by the shape of the joint and the shape of the bones that make that joint. And then we'll talk about, after that, we'll get into the synovial, some specific synovial joints of the body that are very, very complicated, like the knee joint, the shoulder joint. Talk about those a little bit. And then we'll wrap up with some diseases and disorders. Okay, so 6 different types of synovial joints. So when we look at them, we've got plane joints, hinge joints, pivot joints, condylar joints, saddle joints, and ball and socket. So we'll just take a look at some of the graphics to explain these ones. So the plane joints, remember when we talk about planes of the body, etc., you kind of see these straight lines. So a plane joint is where you've got kind of straight lines of 2 bones that are just gliding a little bit past one another. Remember how we talked about gliding as the name of one of our different types of movement? So at a plane joint, this type of gliding non-axial movement occurs. So like between the small bones of the wrist and the ankle, etc. Okay, then uniaxial movement, like a hinge joint, right? So a hinge joint, like the elbow, like the knee, right? Those are going to be hinge joints that will only move in one particular plane, right? So even this is going to be a hinge joint. So it's only going to move in this axis. You start doing this stuff, oh no you didn't, right? That's down here, and that's actually a different type of joint. So here and here, these are just hinge joints. I'm not one of those people that can move just my last phalanx, but hinge joint should only go in one axis that we see there. So flexion and extension. All right, also now we also have pivot joints. So pivoting is like rotating, right? And so when we're talking about pivoting, like where the atlas and the axis, that was pivoting or rotation. So we have the dens of the axis, and then we have the atlas sitting on top of it, and it's going to rotate like that, right? Uniaxial movement of rotation. So that's a pivot joint. We're pivoting. Same thing, it happens between the radius and the ulna. The head of the radius kind of pivots right next to it when you're doing types of movements. Okay, condylar joints. Now condylar joints are one of these unique ones, don't have in a lot of places, that give us biaxial movement, so in 2 directions. So when we look at that, metacarpal phalangeal joints, right? We said no, no, no. So they're saying you can do 2 movements. You can do this, and you can do this, and that's basically it. So you start doing other things, they consider that to be kind of 2 of those. You're combining vectors, if you will. Anyway, condylar joints. Then we have saddle joints. So saddle joint is even more specific. So it occurs at the carpometacarpal joint of the thumbs. So when we're looking down here, right, this is biaxial movement, they say. It's like 2 saddles that are coming together. That's why they call it a saddle joint. So we can move like this, and we can move like this. So that's a saddle joint, occurs the thumbs and the carpals. And ball and socket. Ball and socket's pretty straightforward. Shoulder, hip. Okay? All right, so these give us multi-axial movement. You can move in all different types of planes. Alrighty, so those are different types of synovial joints based on the movements that they can make, based on the shape, etc. I know, subcategories. Alright, now let's look at some selected synovial joints and some of the details associated with them. Knee joint. Knee joint's an important one, lots of different structures involved. When we look at the knee joint, of course we're going to have the femur as the proximal bone. The distal bone is going to be the tibia. And then we also have a patella in there, right? The patella is attached to the tendon of the quadriceps muscles up here, and then down here, it's called the patellar ligament. Technically, this is one piece of dense regular connective tissue, but in this area, it's between a muscle and a bone, so we call it a tendon. And this area is between a bone and a bone, so we call it a ligament. All right, so besides that, though, we see that this is obviously going to be a synovial joint, and you can even see there's some bursae associated with it. And we can see some interesting ligaments, too. So we're seeing this in a parasagittal cut. We're viewing it from the side, and we can see that there is a capsule towards the back here, but inside of the joint, we can see some other structures. There's some extra cushions here that are called menisci, and you can also see there's these X-shaped ligaments on the inside of the knee, right? They form a cross, and these are the cruciate ligaments, right? When you talk about crucifixion, right, on a cross, so these are the cruciate ligaments. They are inside the knee, and they keep the femur and the tibia from shifting this way, anterior, posterior, like that, okay? And the way that they are named is the anterior cruciate originates, like we see here, on the anterior surface of the tibia, and then it goes back to attach to the posterior of the femur. The posterior cruciate ligament, the PCL, originates here on the posterior part of the tibia and then goes forward and attaches to the anterior part of the femur. So the ACL and the PCL are named for where they attach on the tibia. So remember that. All right, other things. When we look down, if you will, a superior view on the knee, here we can see those cruciate ligaments, right? Posterior one, this is the posterior side of the tibia. Here's the anterior side of the tibia, so we can see them coming across. They're going to be forming that X. And here are the menisci. It kind of forms almost like a figure 8 through here. And those cushion the condyles of the femur that are coming down. And they kind of cup them a little bit like the acetabulum comes around the edges of the head of the femur. So it gives us some support so that the femur isn't going to slide off of that articulating surface of the tibia. So medial and lateral, right? Lateral side, this is the outside, if you will, over here. So it's going to be a lateral meniscus. And then the medial meniscus is going to be over on the medial side instead. So when we look at it, like we said, there's going to be a number of different tendons and ligaments which learn to actually stabilize it. So here's our tendon of the quadriceps muscle. Here's our patellar ligament. There's also these side ones which are called the retinacula. And here you hear about these for sure as well. This is on the lateral side, this is on the medial side. So these ones on the sides are called the collateral ligaments. So this one here is called the fibular collateral ligament. It was also once upon a time called the lateral collateral ligament. So you may have heard of it like that. This one over here, they've changed the name to the tibial collateral ligament. That used to be called the medial collateral ligament. Okay? So we can also see a little shot of our lateral meniscus through here, our medial meniscus in there, etc. All right. So we mentioned the collateral ligaments. There are some popliteal ligaments as well. The popliteal space, remember, is going to be on the posterior side. So the popliteal ligaments are on the posterior side. You won't have to learn these for lab. We do the menisci, we do the cruciate ligaments, we do the patellar ligament, we do the collateral ligaments, but you don't have to worry about these oblique ones that you see there, or the arcuate ones. Now here's something interesting. This is the anterior view. That also helps to see our cruciate forming the X, like this. It also shows us our lateral, if you will, fibular collateral ligament and the medial, and our menisci. But here's another thing that's kind of interesting as well. So those are basically the different ligaments you have to know. But this is an interesting one here. A few years back, they actually discovered a new ligament of the knee. It's called the anterolateral ligament. So here's the lateral collateral ligament, also called the fibular collateral ligament, because we can see that it attaches to the fibula, right? But this is one that kind of comes at a little bit of an angle, and for a long time they thought that this was just kind of interpersonal variation, that this was a little section of fibrous material that came off of the fibular collateral ligament, and it wasn't really anything, until they started doing a lot of observations on different cadavers and showing that this was a distinct ligament on lots of different individuals. And so it gained its own name as the anterolateral ligament. So it kind of comes at an angle like that. So again, it's kind of interesting You think, we've known all this stuff about the body for forever. What's new? I could get a textbook from like 1960 or something like that, and it'd be the same, right? 206 bones, etc. New. It happens. Okay, so just diseases and disorders, more so disorders, but a little bit of diseases at the end. Knee injuries. Knee injuries are big, right? So especially when you get hit from the side, especially from the lateral side, that's going to blow out. You're going to get compression here. You're going to get expansion on the medial side. And so what you're going to see is oftentimes this medial collateral ligament is going to tear, and that is connected to the medial meniscus. And so both of these will tend to go out at the same time. You hear about ACLs as well. ACL could happen at the same time. That is more restrictive in the anterior-posterior movement. But if you jump wrong and your knee goes backwards, etc., or something like that, you could tear those cruciate ligaments as well. More commonly the anterior than the posterior. So football season's coming up. You're going to be hearing about these, right? All right. So knee joint and shoulder joint. So this is the most freely movable joint in the body. It's a ball and socket joint. But if it's going to move so free, if you're going to be so free, it's going to be less restricted, less protected as well. So when we look at it, right, remember that glenoid cavity, it's pretty shallow. It's almost like a fossa. And then we have the head of the humerus attached to it. So it gives us a lot of movement, but not a lot of protection to stabilize it. But we have additional structures, like we mentioned, that are going to help with that. So we have the bony structure, but we have a lot of ligaments as well as tendons that are coming up to support it. So you can see there are glenohumeral ligaments, so that goes from the glenoid cavity to the humerus, so that's going to help to attach it, right? So there's also the coracohumeral ligaments, so they go from the coracoid process to the head of the humerus, right? And we have the greater and lesser tubercles that we see there, so you can see how we're attaching there. There's also the coracoacromial ligament that goes across the top over here. So lots of different ligaments, but like we said, in terms of stabilizing joints, a lot of times it's the tendons and keeping those muscles toned and fit, etc. So there's lots of different tendons that come up here as well. You can see a tendon right here. So this is a tendon of the subscapularis muscle. Remember we have the subscapular fossa on the inside, if you will, on the anterior side of the scapula. That's where the subscapularis is. So there's a tendon coming in there. There's also the different heads of the biceps coming up, etc. Especially this long head, like we see here. So it's coming up, it's coming all the way around here. So that helps to stabilize and keep that head of the humerus on the scapula. So long head of the biceps brachii is a major stabilizer, to be sure, but there's also 4 rotator cuff muscles that help to keep that head of the humerus on there. Those are the subscapularis that we mentioned already, supraspinatus, infraspinatus. Remember, those seem familiar, right? Above and below the spine of the scapula. So we have those fossae in there. So deep here to trapezius, right in here, there's what's called supraspinatus. Down here, inferior to the spine of the scapula, is going to be infraspinatus. So these come across over here, and they help to keep the shoulder in there. Subscapularis is deep on the other side, and then teres minor also is going to be in this area here. So we have those 4 rotator cuff muscles that also encircle the joint, and then, like we said, that long head of the biceps brachii coming across here also helps to cinch it down. Elbow joint, we're not going to do too much in terms of the elbow joint in lab, but as you can imagine, kind of like the knee, right? 1 big bone, 2 small bones. We're going to have collateral ligaments on the side. There's annular ligament going around as well. So they help to hold those bones in place and stabilize it. Now, the hip joint, for sure, we'll need to know about the hip joint, right? So a deep acetabulum, big head of the femur that is supported by it. Now, that's potentially going to degrade through time, and as that acetabulum, as that cup becomes more shallow, then there's more of a chance for dislocation, etc. Even the bony structure of that acetabulum, there's fibrocartilage around the rim of it that helps to deepen it even further, and that's called the labrum. And that also happens up in the shoulder, but much more so in the hip, where we're stabilizing the body. So when we look at the ligaments here that are holding the femur in that acetabulum are very simple. They have the names of the bones that they connect, right? So if we look at it, we have iliofemoral, right? Between the ilium, which is up here, right? This is all ilium up there. Bad drawing, but you get the idea. And then we have ischiofemoral. Remember that this is going to be the pubis through here, right? And the ischium is going to be back here. So the ischiofemoral ligament is going to be between the femur and the ischium. So this is the posterior view. And then when we have the anterior view, again, it's a little bit clearer. We can see iliofemoral also has a branch over here between the ilium, right? The ilium is the more superior part. And then pubofemoral. So we see pubic bone here. So pubofemoral ligament there. So pubofemoral and iliofemoral are easier to see on the anterior side. We rotate around to the posterior side because that's where the ischium is, right? Remember the ischial tuberosity? That's your butt bone, if you will. So ischium is seen a little bit more on the posterior side. We also talk a little bit about the temporomandibular joint, right? TMJ. We say that, oh, everybody has TMJ. So remember what we have is a mandibular fossa, so the temporal bone, and then we have, right, the mandibular condyle that goes into it. And then we're going to have connective tissue, ligaments, etc., that are going to hold it into place. This is actually one of the most commonly dislocated joints that we have. Okay, when we look at that hinge joint of the TMJ, so mostly it's hinge, right? Right? Mostly it's hinge, but you can also get a little bit of gliding in there too, a little bit of side-to-side movement. All right, other things that we find in terms of these troublesome joints, the sacrifice of being free and then not being as restricted, not being as protected, is we can have that damage like we were seeing in terms of ligaments and cartilage, etc. And so when that happens, whether it's compressed or whether there's shear stress, etc., then these connective tissues we know don't regenerate very well. Cartilage doesn't, ligaments don't, etc. So oftentimes they have to be repaired, sometimes surgically, arthroscopic surgery. Remember arthro? Arthro means joint. So you put a scope in the joint to be able to see what we're doing. They can put a light in there in a different hole, and then they can inflate it a bit so they have more room, and then they can actually put tools in there and snip up loose ends or add in material. So they can take, if you have a blown ACL, what they can do is they can take a slice out of your patellar ligament, right, like right out of the center of it, and put it inside of the knee and replace and kind of screw it down and replace your ACL. They can also use cadaveric from a cadaver material. So in any case, we need to see what's going on, so they'll do that arthroscopic surgery to take a look. Hopefully they'll be able to take care of it using the arthroscopic surgery. It's very invasive, easy to recover. If they have to do a knee replacement or something like that, or a hip replacement, then they're opening it all up. You should see some of the YouTube videos on that. It's always interesting to me, you know, you see some of those surgery videos, how rough they have to be when they're doing the surgery, you know. You figure there's going to be some soreness at the joint or whatever, but they do some big work when they're replacing those joints. Knee joint, they're like sawing off the articular surfaces of the bones and replacing them with synthetics, etc. And they have to put in the stabilizing bar in there, and so they're using a bone saw after they fillet it over, and they're cutting across the top of it, and then they actually have like a T stabilizer bar that they hammer down parallel to the femur, and what that does is it's going to stabilize the inside of it so that they can put some of their parts on there, the replacement parts, the synthetics or whatever. But I mean, they're in there with hammers, and you see the whole limb going around, etc. Ugh. Amazing, but it works. And oftentimes these days, right, they're encouraging people to get up that very same day when they come out of anesthesia, because the faster they get moving again, the more blood flow that goes to it, the more demands. We tighten up those muscles, we help to stabilize the joint, etc. Even with hip surgery also. Okay, other things, sprains are where the ligaments that are holding these bones together are stretched or torn. So this happens a lot, right? If you sprain your ankle, sprain your knee, or whatever. And with these ones, again, it depends on how severe the sprain is, right? If you just stretched it, well, so it's going to hurt for a while. But if you stretch it so much that some of the fibers start tearing, then there's going to be a problem. They may actually have to kind of try to sew them together or use grafts, etc. Now, if we get extreme stretching, you may actually get dislocations, right? Where the bones are stuck together and now they kind of pop out, like we said, like a jaw coming out of its joint, etc. So when the bones get out of alignment, then they have to be put back into place, right? So this is called a luxation. So we have to put them back into place, and then of course you're going to have some strain on that joint. You're going to have some inflammation on the joint and pain associated with it. You're going to need to strengthen that joint again. So luxation is a full dislocation. A subluxation is partial. So you hear about people dislocating their shoulder joint, etc. We mentioned bursitis and tendonitis again, right? This is swelling of the bursa, the little synovial bag, or of the tendon, etc. So that can happen. Tendonitis, you hear about that. So again, ice, rest, compression, elevation, all that type of thing, right? And then arthritis too, right? So this is a swelling of the joint itself. And there's lots of different reasons why the joints might swell. Could be just from overuse, but you're going to get pain and stiffness and swelling at the joint. It could also be pathogenic, different infections that have occurred in that, like the synovial fluid or something like that. Or also it could be your own body actually attacking you. So just a couple types of arthritis. Osteoarthritis, the bone arthritis, is due to wear and tear. As we get older, even though we have the cartilage, etc., it doesn't last forever. It doesn't repair itself very well, so it wears down. And now you're grinding bone on bone. The bones take an odd shape. We lose some of that synovial fluid. We lose a lot of fluids as we get older. And so now it's like kind of running your car without oil. And the shape of these particular parts, which were very smooth once upon a time, are not so smooth, so they're grinding on each other. You may even get like bone spurs in there. You can imagine how painful that is. But this is wear and tear arthritis, which is going to happen usually over time. But there's other types of arthritis. For instance, there's rheumatoid arthritis. Rheumatoid arthritis is actually an autoimmune disease where your own defenses, your own white blood cells, are attacking the joints. So this also happens a bit when you are older, but usually like between 40 and 50, and it's not, like we said, it's not necessarily a use thing. This is your own body that's attacking you. We'll talk about other autoimmune diseases and how your immune system is supposed to be able to protect your own cells and attack foreign cells, and how it may lose the ability to do that. But that's another topic that we'll cover in Bio 202. So for now though, that gives us the end of chapter 8 on articulations or joints.